I'm a co-lead of the South West Learning Disability Collaborative, but I'm a GP by profession, and I'm also a clinical coordinator at NCEPOD. So I was one of the coordinators on this report, and my co-author is David McWilliams, who's a professor of critical care and a physio by background. So what I'm hoping to do today is just give you a quick overview of some of the findings and some of the recommendations, share some of the resources, and thanks to Saoirse, who's going to really highlight some of the work that can be done in hospitals and the benefits of having a learning disability team embedded in providing care. And then I'm just going to ask a few questions. There's things for you to think about your practice and whether there might be areas that you would want to improve. Next slide, please. So very quick thing on NCEPOD, it's a national confidential inquiry into patient outcomes and death. And what's different is that it's the suggestions for improvement are made by clinicians. And we want the aim is to improve the care given to patients. So some other reports published recently were looking at limb ischemia and then emergency surgery in children. One that's going to come out soon is pleural procedures, such as how you put chest drains in. So very much clinical led. And it's not an audit or research, but it's a snapshot. And what's so different is we have the ability to look at the notes, and people like Rachel provide immense skills of reviewing. And I'm not sure if Emily Richardson and other colleagues who were reviewers of the notes are on this call, but reviewers are so key to what we do. And if anybody wants to get involved, please do. It's really it's great to have MDT working. And so we also triangulate this information from the notes, from the reviewers, from the clinicians who've provided the care, from the hospitals who say what they're doing. And then we also have focus groups, patient surveys, and online professional surveys. So a lot of data. Next slide, please. And I should mention, actually, when you see the QR codes, if you take pictures of them, we will share the slides, but that will take you directly to some of the reports that I've been linking. So as Kim said earlier, the objectives were to identify avoidable and modifiable factors associated with poor quality of care. And we were looking at all patients with a learning disability aged 18 or over who were admitted as an emergency over a 6-month period. We identified nearly 13,000 patients. From that, we looked at 1,000 patients for further review and from this, we got information from the 666 clinicians who reviewed the patients. We looked at the case notes. That was a significant piece of work because every single case note was there, had to be anonymised. You can imagine how much information was there. We also have information from primary care questionnaires. 199 hospitals completed organisational questionnaires, so significant involvement across England. Over 800 health and social care professionals, and then also patient surveys and carer surveys. Next slide, please. And so we made 5 recommendations, and the first was to accurately record a person's learning disability in the patient notes and on learning disability registers. I won't talk about the definition because thanks to Rachel for doing that. But what we really found really surprising was that a third of patients had learning difficulty rather than learning disability in their notes. And the two terms are often used interchangeably. And so we wonder as how many patients who were only coded as having a learning difficulty rather than a learning disability weren't identified. It's a recurrent theme, and I found examples not just in clinical cases but also are nice. The latest sepsis guidance spoke about people with a learning difficulty, and thanks to Ken Courtney, the National Clinical Director for Learning Disabilities, who got that changed. And then we also found terms such as shortened to learning disability. And in one clinical entry, the clinician writing the notes had written LD, learning disability and learning difficulty. So you can see what a challenge there is. So, that's something really to think about. Next slide, please. And so if we know somebody's got a learning disability, how do we share that knowledge? Because it's not just for the person in front of you now, but it's when they come back next week or when somebody else sees them in an outpatient's appointment. And so nearly 90% of organisations said they used alerts or flags, but actually only just over 50% of patients had alerts. So hospitals say they're doing one thing, we're not quite finding that. So the questions I'd be asking is, do the admission team know someone has a learning disability when they arrive at the front desk? I'm going to share a video later, and that very much talks about the issues when somebody with a learning disability arrives and their behaviour is more challenging and people don't know why. Do you have alerts and pop-ups? if you know someone's got a learning disability, how do you let the learning disability team aware of what's happening? So sure, we'll talk about that. Do you have it, if you've got electronic patient records, is that on the hospital passport? Alex Barkley from Heart says she does a virtual round every morning of everybody with a learning disability in hospital. And then the other bit that I wanted to also mention is the miscoding, which we've just touched on. Next slide, please. And so this obviously is the tool that Rachel mentioned, that if you have a look at the QR code, that will take you straight into the tool. Next slide, please. And I just wanted to share some, one of the things we do with NCEPOD is look at practical solutions. And Alex Barkley is a critical care outreach nurse working in Hertfordshire. And this is what they give to their patients with a learning disability. So you have a wristband saying that, giving your hospital details, a wristband with your allergies, and then have this one to show that you've got a learning disability. Apparently, they've only had one patient ever say no. Most patients find it really helpful. The carers and the families really like it. And it means that not only do the clinicians delivering the care know someone's got a learning disability, but also the porters, the housekeeping staff. You might need a bit more help with your food. You might not be able to complete the order for lunch. Really simple strategy, low cost, which can raise awareness of what's happening. So have a think about that. Also looking, it's got Martha's Rule telephone number on there, which we like. Next slide, please. So if we know someone's got a learning disability, how can we remove those barriers to care which are required under the Equality Act of 2010, so known as reasonable adjustments? We found that reasonable adjustments were much more likely to be made if there was an alert in the patient record. But patients and carers often weren't asked about the reasonable adjustments. And there's often that lack of understanding that reasonable adjustments can be organisational, so it could be disabled parking, accessible loos, but they can also be very individual. So for one person, it may be that they get really distressed by noise, so they need headphones. How do you know what can help that individual? And if you can help that individual stay calmer or be involved, then that will provide better care for them. But also I feel makes it easier for us to deliver the best care for as well for that individual. And reviewers found that if the carer was involved, reasonable adjustments were much more likely to be made. And one reviewer said the carer knew the situation well. Reasonable adjustments were made without a second thought, and they worked closely with the family. Next slide, please. So if we know what reasonable adjustments help, are they being flagged in the notes? And as you can see, in the acute hospital setting, only about 50% of clinicians said yes. And this is good information. Why aren't we sharing it more in the community, but still room for improvement? And that's probably this lack of flagging of reasonable adjustments probably reflected in the fact we found that there was documented evidence of reasonable adjustments being made for only just over 40%, and for 21% of patients they were made inconsistently. So having the alert made it much more likely adjustments would be made. But interestingly, less than half of the health and care social professionals thought it easy to flag adjustments. And where's the low, is that a low cost intervention that you can make to start raising awareness? Next slide, please. Because adjustments don't have to cost money. This was one that carer said that rather than the person she looked after waiting in the surgical ward, the day surgery unit for an operation, that the person was able to wait in their own room, and therefore they were much calmer, and therefore that made life easier for the patient, the carers, but also the staff delivering the care. So it's often not complex. Next slide, please. If you want to know more about reasonable adjustments, the Royal College of Physicians have got a great tool. Again, it's the Acute Care Toolkit based on some work from Hertfordshire, and the video I'm going to share later also talks about these aspects where you can look. So the thing I would say to you is what reasonable adjustments are available in your organisation? What's available in your department? Do you have noise cancelling headsets? How do you know what reasonable adjustments could help? Do you have flags? Is it written on paper, which therefore it's less likely to be accessible? Do you ask carers who might be able to share practical solutions? And how do you share what reasonable adjustments help? Next slide, please. And so, as I've just mentioned a couple of times, this is Gavin, who is an expert with lived experience for learning disability based in Hearts. He's recorded a really fantastic video last week for the NCEPOD launch. Hopefully it'll be on the website now. It's about 13 minutes long, so not too long. A lot on adjustments, but also quite helpful flags on making mental capacity assessments. So if you've got time to have a look at it later, do so. Next slide, please. The third recommendation is to use decision support tools to assess mental capacity assessments. And the bit that we really have to emphasise is that a person with a learning disability shouldn't be presumed to lack mental capacity to make health-related decisions. The reviewers tend to review the notes often in the same room, and it was a recurrent theme that, you know, a statement had been made, a person has a learning disability, so unable to make that decision. It might be that they can't make a decision, but actually most decisions vary. It might be with, do you want a cup of tea, or it might be you need some surgery. And if people are making more complicated decisions, what information can we provide so they're able to do so? And this lack of understanding amongst clinicians on capacity is reflected in the fact that formal mental capacity assessments were made consistently for about 30%, inconsistently for about just under 10%, and not at all for about 60% of patients. So we know, Leader knows that delay and problems assessing capacity can have negative impact on care. So how can we improve this? Next slide, please. The decision supports can be of use, and they are present in 95% of hospitals. But what really surprised us was that despite the decision support tools, just over half of the patients who didn't have a formal assessment were considered by the reviewers to have needed one. And what was even more surprising was that just over 60% of healthcare professionals who have assessing mental capacity as part of their role didn't feel confident to do so. So what is happening that people don't feel confident to assess capacity? Next slide, please. And the impact, it can be considerable. So I thought we found a lot of issues on accessing CT scans. And I've had quite a lot of involvement with our local hospital, and they were saying often just they want simple things like having a double appointment so that you've got longer to explain to somebody what a CT is. And this was a man in his 50s who had pneumonia, had a hemoptysis, likely to have a pulmonary embolus, but he refused the CT scan. So they said he couldn't decide. They therefore commenced anticoagulation, so making his blood thinner for a PE without confirmation. So given quite significant medication with no diagnostic proof. And I can imagine when that medication was reviewed at a future date, somebody could easily say, well, there was never any confirmation, so does he need to continue? And so by not involving that man and giving him the access to investigations, negative impact on his care are particularly important, because previously giving him time for the CT had meant that he'd actually agreed to CTs. Next slide, please. And if you want to know more about mental capacity, this is a video the Learning Disability Collaborative produced with some practical tips. It was to support annual health checks, but all the learning is relevant. And the questions I would say is, do you feel confident assessing mental capacity? How do you record your decisions? Are decisions part of a patient's electronic patient record so they can be reviewed? And do you have access to a decision support tool? And I would also say, do you have a mental capacity lead in your organisation? And if so, can you ask them, how can these problems be addressed? Next slide, please. If you want to know more, this is some advice, this is some guidance produced by NHS England. It is actually for acute settings, but we've just updated it for out of hospital settings. It's going through its final approval with NHS England. As you can imagine, with all the challenges going on, it's taken a bit longer, but the principles are the same, and it's a really useful resource. Next slide, please. And the fourth recommendation is to involve people with a learning disability in their care, and also the carers. And found that only just over half patients were involved in decisions regarding their care. And significantly, in just over 40% of cases, there was no involvement of the patient or the patient's carer at discharge, which we think has an impact. Carers were involved in about 45%, but it was inconsistent in about a third of the cases. There was often no involvement of the patient or carer in planning ongoing care. And we think this is particularly significant because a fifth of the patients were readmitted within 30 days of discharge, more than 3 times higher than the readmission rates for people without a learning disability. So what's going on? Why are people bouncing back, particularly when nearly 60% of those patients who were readmitted, it was related to the original admission? So what's going on? Why are people coming back? Is this because they're not involved in their care? Next slide, please. And so if you want to involve people, what information can they bring in? Thinking of hospital or health and care passports, Saoirse's going to go into that in more detail, but it's a great opportunity to find out what's going on, what's normal for that person and where the changes are. Passports certainly make a difference. Next slide, please. We can also ensure that we take observations as recommended by the Patient Safety Alert of 2018, should take a full set of observations. So, but it was found that 15% of patients didn't have a full set of observations, so they lost the value of News 2, National Early Warning Score, to identify when they were very sick. Most commonly missed elements were consciousness level and respiratory rate. And if you think of respiratory rate, we don't need to touch anybody. You can stand at the end of the bed. So why is that not being recorded? Particularly as a clinician, that's the most sensitive. If I could only have one observation, that will be the one. If subtle increases in respiratory rate can support deterioration. And pain wasn't recorded for about 85% of patients. So if somebody's behaving oddly, could they be in pain? Why is that not being asked? And you can see the potential of News 2 if somebody's unable to give a history. In this case, 30-year-old man, and News 2 was 9, therefore immediately escalated as being really sick, had sepsis, and the right care was delivered at the right speed. Next slide, please. And not just taking observations, but also talking about the soft signs, which are really key. All carers I know say they can set, particularly family carers, because they say they know when the person they look after is unwell. And for those of you who know, I've got a nephew with profound learning disability. He can't speak, but he's very noisy. We know he's in the room. When Toby's quiet, we know he's sick. That's a really important soft sign that we as clinicians, as healthcare professionals, need to listen to. And this case was lovely because the carers just said that the person they looked after says woo wee when she's happy, and when she's not, she frowns. And it's that kind of subtlety that you can see there's a change in someone who can't tell you they feel more unwell. So I just ask you, do you ask families and carers about soft signs? And if Emily Richardson's on this call, I know it's something that she's thinking of looking at in the Bristol area. So do kind of watch out for that work if she manages to land it. Next slide, please. And so what do carers want? They're so important. The most common support offered by hospitals is open visiting hours, although in fact often people said that didn't happen. But this carer survey said what they really wanted was free parking, practical. They also wanted access to loos. If you haven't got access to, some of the carers I was talking to with Susie, our senior project manager, was saying, if you don't have access to a loo, if you can't use the staff loo, you worry about when to go, and you can guarantee that the ward round happens when you're out of the room or some crisis happens. Could they have access to a staff loo? Doesn't cost money, but what about that? Parking top of the list, but not prioritised by hospitals. And another thing carers asked for was refreshments and meals. Again, it means you haven't got to leave, but it also acknowledges some of the significant costs of trying to buy food on site, particularly if you're driving distances, worrying about where to park if you're looking after somebody. And the question I'd ask you is, do you have a carers policy? And if so, what's provided? Next slide, please. And do look at, this is some work from Norfolk. It's got some really great ideas on their website, but some of it is just having a lanyard. I'm a carer, so people know if you're using the staff loos. If you're going down to perhaps get a cup of coffee, perhaps you could, if you want, it's important not to have to be kept waiting in the line. But most of the carers thought a carer passport would be really helpful. Lots of different ideas in different hospitals, very happy to talk about that, such as a carers hub, which can help support carers. Next slide, please. And also, I just wanted to highlight this one, the Learning Together patient leaflet, which the NCEPOD team produced. One of the main things was to tell staff you have a learning disability. I think sometimes people are like, oh, I don't know if I want to say that, but actually people with a learning disability often say they want others to know. So be upfront, say that's what you've got and you need some help. Ask for adjustments, bring your passport, and then ask about the learning disability team. And before you go home, just check what's being decided. In the discharge summary, only 40% were coded as somebody having a learning disability, a lost opportunity to populate hospital records. But that's, can you update your your discharge summaries just to include that coding? Next slide, please. And the final one is to commission local learning disability support services to improve the care. So Sorsh is going to give much more information and practical examples, but we found that only 20% of hospitals were these learning disability teams multidisciplinary. Most were single profession, and actually the majority, 40%, were a single individual. I gave a talk last week in Northern Ireland, and it's one nurse dealing with all the trusts. I mean, I'm doing amazing work, but one person obviously can do much less than a team. And learning disability teams are often only available during weekday hours and sometimes only limited support for emergency admissions. It's particularly important because learning disability team involvement was associated with better care. But I would also suggest that it's not just learning disability teams have the opportunity to be involved in day-to-day care, but they can also be involved in upskilling all of us, all the healthcare professionals delivering the care, so that we feel more confident to assess capacity, make reasonable adjustments. And an example was given to me last week of a dentistry team who look after people with a learning disability. And working with the learning disability team, they've developed an accessible pathway. They've got the reasonable adjustments. They're confident in assessing mental capacity. And they've actually now delivered this with actually no involvement of the learning disability team, which to me is actually what we should be doing. Is that the learning disability team, yes, they can be helpful day to day, but they can also help upskill and provide the teams the confidence to deliver the right care at the right time, and particularly in the middle of the night when there's less, when other colleagues aren't going to be available. So next slide, please. So I hope that's been a really quick overview, but I hope that's been helpful. And the lessons I would suggest to take away are first to identify, code and share that someone has a learning disability. David and myself were talking last week about what we feel is the most important recommendation, and we feel this is key. If you don't know that somebody's got a learning disability, then actually most of the other stuff can't happen. Raise awareness of the importance and impact of regional adjustments. We know they can't always be made all the time. In a busy ED with a long waiting time, it may not be possible to offer a quiet room for someone to wait, but it might be that somebody has a favourite toy, and if you can ensure that that favourite toy is there for them to cuddle, then that could make them feel much more confident, much happier, and much better able to work with others to find out what's going on. So they don't have to be expensive, but we recognise that regional adjustments can't always be delivered. We need to upskill and improve clinicians' confidence to assess mental capacity. That's a really key one. Have we got, there are tools, but how many electronic, can they be embedded in the patient's electronic record so you can support, so it can help you make decisions, but you've also got a record there for somebody else to refer back to easily, and it also can help audit trails. People with a learning disability in their care should be at the centre of decision making about hospital care. Unfortunately, we found that DNA CPRs were written without access to discussion with patients and their families, and that acute hospital learning disability teams should be involved. But the main one, and this comes from Anthony Mikulski, who's another clinical coordinator at NCEPOD, and as he said, we should understand that meeting the care needs of people with a learning disability is everyone's responsibility, not just that of specialist services. We've all got a role to play to improve the care we provide, and let's hope we can improve the health of people with a learning disability.